Equilibrium. Here's the agenda for today. We're going to cover dizziness. Syncope has 3 things under it. Vertigo, peripheral, and central have a bunch of disease states. And then we got seizures over here. I think if we get through this much, we'll kind of check and see how we're doing brain-wise. And if we're like tapped out on neuro, we can roll this into that space that we got with TBI. So we'll see how things go. We'll kind of take it by ear. Don't worry if you see 100 slides. We may stop at the 60 or 70 mark if we hit the things we need to do. But I at least want to get through the dizziness, the syncope, and the vertigo. All right, so dizziness is 1% of office visits in the US. Older you get, the more likely it is that we're going to have it. 20% of people reporting that they have some degree of dizziness. Dizziness is something you see on people's problems list. It's not a great diagnosis because you're like, all right, what actually causes dizziness? The 3 things that we're kind of thinking of is that vertigo, that presyncope, and that disequilibrium. I like this chart here because it kind of shows you some of the words that are associated with that. Don't worry about memorizing it for a test. I'm not going to feed you a bunch of them and ask you to fit it under which of these categories it is. But when you're actually dealing with older folks and they say, I'm feeling dizzy, you're like, all right, are we passing out? Are we having, true like sensation of the room moving, or are we just feeling like we're unsteady on our gait? You got to kind of fit it into one of those categories of vertigo, presyncope, and disequilibrium. And I know you guys have been exposed to the word syncope before, correct? I think the sophomores as well. That's not a strange and foreign word. First step, clarify what the patient means by dizzy. Vertigo, we're thinking false movements and spinning kind of grossly. Presyncope is that feeling that we're about to faint. And that disequilibrium, think, hey, they're imbalanced in their gait and they're unsteady. And our differential, I do that early because the workup's a little bit different depending upon which category it's in. Some of the words they may use, they may say lightheadedness, faintness, spinning, giddiness. You have to kind of fit it into those categories that we understand because that's going to drive your differential. And then some of the misleading terms, they may say, hey, I'm mentally confused, I'm dizzy all the time. That's not kind of what we're thinking here. Blurred vision, headache, tingling can all be described as feeling dizzy initially, and you dig into it and you're like, all right, this doesn't sound like that triad of presyncope, disequilibrium, or vertigo. It doesn't really fit it cleanly. All right, so let's keep this slide. This is a good one to test on because I'm going to ask you like, hey, can you define one of these ones and give you a bunch of them. It even has 5 options in it. So vertigo is that sense of motion, indicates a dysfunction within the vestibular pathways. Here's the vestibular pathways. Semicircular canals, otolith organ. You guys remember some of this from ENT? Did we cover a lot? I think the sophomores haven't had ENT yet, so we'll spend a little more time on some of those vertigo symptoms. The juniors might have been exposed to it before, so we'll teach to the sophomore level. I think it's okay to have a review. Just let me know if we start going too far out or you're like, hey, we've already been exposed to this 10 billion times, slow down, but I'm gonna teach towards the sophomores. All right, disequilibrium. I think of this guy that's falling here, it's being unsteady. It's often associated with some type of gait abnormality. Disequilibrium.
Man.
Yes?
Can you hear me?
Hi.
I just want you to know that the sophomores have already done HEMT.
Whoa, I'm gonna go through it super fast then. No, we'll take our time. If I'm going too fast or like, hey, this is new information, just let me know. But when we hit some of those individual ones, just let me know if they're unfamiliar to us anymore. Thank you so much for the heads up. All right. Lightheadedness is this sensation that one's about to faint. And like, all right, what's the difference between lightheadedness and presyncope? They're very similar. Lightheadedness, think of it kind of being a much longer spectrum, like, hey, I'm feeling a little bit lightheadedness. Presyncope, use that when someone's like about to pass out. It's that immediate stage right before. This guy looks like he's about to pass out. We made him do blood draw when we do the IV labs downstairs, and now he's gonna pass out on us. With presyncope, always think of transient cerebral hyperperfusion. That's what's actually causing it. Vertigo, semicircular canals. Disequilibrium, whole bunch of different things, but we're unsteady. Presyncope, associate that with transient cerebral hyperperfusion. And then we can have this multisensory deficit dizziness. This is more of your elderly folks because their eyeballs don't quite work right no more, their ears don't quite work right no more. They may present with some like combinations of these things. In reality, it's their senses that are failing because you can see grandma here, she can barely see the screen. Ears might not quite work right no more. We may have a lot of different things. So when we think elderly, I think this could be a multisensory deficit. It could be a combination of these things. I put this slide in here as kind of a localization key. Localizing things, as you can tell, is like a big part of neurology. Vertigo, think vestibular pathways. Presyncope, think something's causing cerebral hyperperfusion. And then disequilibrium, I think cerebellar, I think sensory, I think the vestibular system can be involved, and I think extrapyramidal, meaning what's my actual ability to maintain a posture look like? Those are the big systems that are involved with disequilibrium. These two, nice and easy. Disequilibrium, you got to kind of dig through and see which one it fits in, but look for that gait. That's going to be the key differentiator between these different causes of dizziness in patients. All right, so syncope, fainting. Who's ever fainted before? It's okay. It happens, about 30% of the adult population will happen at some point in their lives. It's going to be about 3% of your ER visits. You got to dig out like, hey, how serious do I need to take this workup? How far do you want to take it? Because you could take it to the extremes, or you could say, hey, you just passed out. Here's what caused it. We're moving on with our lives. We're going to pay attention to some of those differentiators so we have a good approach to a patient of, hey, you just passed out. What do I do with you? So if I have dizziness plus headache plus nausea plus unstable gait plus cognitive impairment after someone faints, I think they may have hit their head on the way down. Not every syncope is a simple, like, I'm going to lay down on the ground and pass out now. Some people may pass out in high impact areas, or a place where you really don't want to pass out, and they hit their head, but they don't remember hitting their head. Always think to look. A lot of times I talk to people for a long time, I do the TBI workup, and then I look at the back of their head, they got a huge egg on the back of it. Always do that physical exam to look for additional causes. If someone passes out, they wake back up. Are we expecting someone to be cognitively impaired 30 to 40 minutes after a simple fainting episode? No, typically, and I think it's in a later slide, but that restores pretty quickly. If someone's having transient issues a lot longer, start thinking other issues. So persistent confusion, prolonged tonic-clonic activity. Do we know what tonic-clonic is yet, or is that a new word? We're going to go into seizures a little bit. Sometimes when we have a fainting spell, we can have some degree of muscle movement when it happens. It may look like someone's having a seizure. If that only lasts a couple of seconds, goes away, and it's not a complete writhing on the floor, may fall into syncope. If that's prolonged, typically about a minute to 2 minutes is what we see with most seizure disorders. Don't call it a fainting event, call it a seizure disorder. And we'll cover seizures potentially today, maybe tomorrow. If we have persistent confusion, prolonged tonic-clonic, we have a focal neural deficit when we wake back up, or prolonged recovery, think of something else. Don't put it simply under a syncopal event. So I got 3 general categories of syncope. I got this one that I call the neurally mediated. Sometimes it's called reflex, sometimes vagovasal. That's the kind of 2 under it. Think of anything that my brain is controlling, it's making me pass out. That's kind of closely related to, but distinct from orthostatic hypertension. My medics in the room, have you guys ever done orthostatic vitals before? So that's familiar. Who's never heard of that before, and that sounds foreign? Did we get exposed to that during Clin Skills a little bit? We'll review it real quick together, but that's the one we think of with orthostatic hypertension. Think someone that's been started on a drug that may be offending. Sitting to standing typically points me towards an orthostatic cause. And then I got cardiac sympathy. That's my scary one. That's the exertional one. That's people that are supine. Usually you don't pass out when you're laying down in bed. If that happens, start thinking cardiac. Think abrupt. There's no prodrome to it. It's not like, hey, I feel like I'm going to pass out and you're out. It's just drop attack. And then there's no prodrome with those ones. And we'll go into those individually. So neurally mediated, syncope, vagovasal. Who's ever heard of a vagovasal syncopal event before? That's a really common one that we use in like clinics when we're discussing like, hey, I just think he had a vagovasal event. It tends to be one of the more common ones. It's about half of them all in total. So usually these present with some type of prodrome, meaning like, hey, I'm not feeling so great. You go from that lightheadedness to that true pre-syncope to that syncopal event. It could be diaphoresis, meaning sweating, pallor. People look kind of gray, ashen. You can like see someone when it's happening. When we do the IV lab downstairs, there's always 2 or 3 students that are about to. If you've never seen pre-syncope before, wander up to him and stare at his eyes until he passes out. No, that's not nice. But you may see yawning, nausea. A big red flag, it's rare in the supine patient, meaning someone that's laying down and probably not going to typically have a vagovasal event. Provoke things, pay attention to things that can actually cause this to happen. Fear, pain, anxiety, intense emotion. Sight of blood tends to be a really common one. Unpleasant sights and odors and orthostatic stress. Be careful of this one in clinic, because if you're doing something like a procedure on a patient, always make sure they're sitting down or you're in a position to catch them. Or if like the patient's caregiver is with you and you're doing a blood draw on kiddo, you'll see dad pass out a lot too. Just pay attention and be like, hey, we're about to do something that may be a trigger for people. Make sure no one gets hurt in your exam room with this one. All right. Here you can see that pale ashen color. You kind of pull down, you can see it looks really pale compared to normal. Ashen gray. I think this is just kind of a summary of things. Confusion should be brief, about 30 seconds. If someone's confused 30 minutes out, don't think vagovasal anymore. And brief clonic jerks can occur with syncope, but prolonged post-ictal confusion favors seizure. Do you guys know the term post-ictal yet? Has that been used? Ictal kind of refers to a seizure. So post-ictal means after seizure event.
Sir, you mind adjusting the overhead mic? It's getting a little scratchy.
All right, treatment for neurally mediated syncope is pretty simple. Just elevate their feet like you were taught in, I don't know, from whatever TV show you want, but that's perfectly normal. Ice packs are a really good one when it happens related to, like, if you see someone that you're doing a procedure on, they look like they're gonna pass out, grab a cold pack or two because they're sweating their butts off. Put that on the neck and head, and I give them some type of glucose, like a little bit of sugar water, just to kind of distract them from what's going on. All those work pretty good. And then treat some of the underlying causes. Just avoid whatever stimulus caused that vagal basal event. The other one we see under neurally mediated, vagal basal is going to be the most of it, but we can get this reflex syncope. I put it down here as like the exact vignette that I'm going to potentially ask questions about, but think of an older guy with syncope while shaving, wearing a tight collar, turning his head, and it's stimulating the carotid sinus, these baroreceptors that are in here that tells me what my blood pressure is. If I push on that, if I do carotid artery massage, I can actually lower my blood pressure potential. That's why we avoid doing bilateral carotid artery massage. I think that's choking someone. But what these things do is they stretch out that says, oh, my blood pressure's too, I better decrease my blood pressure. When I push on that, that gives that an abnormal signal. It says, oh, I need to drop my blood pressure more. And that can cause syncope in people. Does that make sense for reflex syncope? Just think of this patient presentation here if you're trying to dig it out or differentiate that from a vagal basal event. Something that's pushing on the neck will cause that. Situational syncope, this is kind of a subdivision of that vagal basal. Sorry, this wasn't quite organized quite right. This one, just think of vagal basal, but now I'm dealing with like a cough, or if I'm eating too much and then I'm trying to digest that. Mituration means peeing. If I'm peeing and I have prostate issues and I'm straining too hard, that can cause a fainting episode, mituration syncope, or defecation, even in older patients with constipation. Just kind of use this as an extension of the vagal basal, meaning, hey, something is stimulating my body. Now it's kind of some more internal things. These are just kind of giving you some background information. That kind of helps understand different vagal basal. It's not all just your young kids that see blood. Sometimes it's older folks that are having difficulty with bodily functions. Passing out in the bathroom, very common. Be careful of that in hospitals. All right, so we got reflex and vagal basals done. We feel pretty good about the neurally mediated. We're going to move on to the orthostatic hypertension. I'm trying to put a backbone to the slides now. Sorry, some of these are repeats, but just so you can keep track of where we're at. So orthostatic hypertension, I got this slide, it's a lot of reading. I like this one. Have you guys ever gone on the CDC PDF of how to do an orthostatic blood pressure reading? You just Google search, hey, orthostatic blood pressure CDC, this PDF pops up, and then I hand it to my medic if they've never done orthostatic vitals before, and it tells you exactly what to do so they can't screw it up. But laying down for about 5 minutes, I check their BP. I have them stand, I check it in about 1 minute, and then standing after about 3 minutes, I kind of recheck it. And again, I'm looking for that drop in systolic by about 20 millimeters of mercury. I'm looking for that drop in diastolic of about 10, and then sometimes we watch out for a raise in heart rate. Hey!
Hi.
God, is that you?
Your audio is cutting in and out for us. It's back now, but I think in a few minutes it'll go back to cutting in and out.
Will this work better? I'll just talk like this the rest of the time.
We're all nodding our heads.
Okay, that sounds good. I'm just going to keep moving them closer to my face. All right. So characteristics that we see with orthostatic hypertension. Orthostatic, think of, hey, people that are rising from a seated position is going to be the most common. Think of polypharmacy in your older people that tend to have a lot of antihypertensives. If we go too aggressive on our hypertension treatment, oh God. If we go too aggressively after blood pressure targets, that's why when we get older, it's like, hey, we're not trying to get down to 120 over 80, like 140 over 90 is an acceptable treatment. We don't want to go too low because then we'll end up in the orthostatic hypertension department. But antidepressants can cause issues sometimes, vasodilators obviously. Do you guys know the term vasoplegia yet? Has that been ever described? Ooh, I'm going to give you a good one. I didn't learn this while I was in school. It came up later when I started hanging out with the critical care people. So the concept is that my veins have a tone to them, that sympathetic, parasympathetic. It keeps a natural tone that keeps my blood pressure in place. If those veins suddenly release, either because of shock or because of orthostatic hypertension or because of a vagal vasal event, they all release, my blood's going to scatter out and it's not going to be able to perfuse my brain anymore. When those veins are plegic, meaning they don't have that tone anymore, vasoplegic, that's referring to, hey, blood's going everywhere but where I want it to be, my veins are all dilated, I'm vasoplegic at this point. Use that term in the future, it's very helpful to describe things. We don't really use it in class because we don't do a lot of critical care stuff, but we pay attention to that when we start talking about adding pressors onto people. We're correcting vasoplegia. Common causes for orthostatic hypertension, diabetes mellitus, because we can see some autonomic dysfunction sometimes. People with nutritional deficiencies pop up. And then physical deconditioning, prolonged illness happen a lot of times in our more elderly folks. They stand up for the first time. These things can cause it, but at the end of the day, I'm looking for that trigger of, hey, I stand up and then it causes me to pass out. And then prolonged weightlessness. So the astronauts, when they come back down, they actually pass out a lot. And you've probably seen videos of them just be like standing there and then all of a sudden they're out. Because they're used to their bodies having like, hey, I don't have to push that hard on the veins to keep blood in my head. All of a sudden I take all that away and all the blood's pooling away. That can cause that orthostatic hypertension to pop up in people too. All right, treatment. First line, I want to remove the reversible causes. If I have a medication, it's probably the vasoactive one. It might be a blood pressure medication. Just do a med-rec review and say, hey, these things are problematic for blood pressure. Next, non-pharmacological intervention should be introduced. Patient stage moving from supine to upright. Take your time and educate them. Be like, hey, don't immediately jump up out of bed and then pass out. Like, take your time to get up, get yourself used to it. Allow your body to reacclimate to being in gravity if you're an astronaut, or if you're an elderly person, making sure we're taking our time as we're transitioning. And then warnings about the hypotensive effects of large meals. If we eat a big thing and we have a lot of blood in our gut, that can cause this to cause a lot of issues because our lower GI tract is trying to digest things. We stand up, it can cause issues. And then intravascular volume can be expanded by adding dietary fluid and salt. And then meds-wise, we got fludrocortisone and midorone. Midorone is an alpha-1 agonist. Fludrocortisone is a steroid. I haven't reached for those a lot of times in these people. Just know that, hey, take care of the things that offend it first. Don't start adding on a bunch of new meds just to kind of correct it. Correct the old meds, slow position changes, add fluids and salt, and if we still have a ton of issues or we can't remove medications because the only thing keeping grandpa from going as crazy is his antipsychotic medications, add these ones on if you need to keep it, if you can't remove some of those medications. All right, reflex, we got it. Orthostatics, we got it. Let's talk cardiac real quick. We're not going to spend a ton of time on it because you guys are going through cardiology, so I'm not going to go through each of the possible causes of cardiac sympathy, but I'm going to kind of give you some of the general clues as you're seeing a patient in primary care. You don't know if it's cardiac or neuro at that point. All right, so cardiac symptoms. Pay attention to the red flags. These are important. If I have syncope during exertion, that's kind of one of my first questions I like to ask when I see a fainting patient. Is like, is it happening when you're resting, doing things, or is it happening while we're working out? If it's happening while we're working out, call it cardiac until proven otherwise. Syncope while supine. I know it seems kind of like two different things, but again, we shouldn't be having vagovasal. We shouldn't be having orthostatic issues while we're laying flat. We have no prodrome. It happens out of nowhere. Think cardiac. And then palpitations, obvious, but ask the questions. And then known structural heart diseases, if it's there in front of you and you know this guy has cardiac issues to begin with, cool. And then that's family history of sudden cardiac death. A lot of times they won't know, hey, this is the exact thing that was wrong with his heart. But we think hokum can cause a lot of issues for younger athletes. Just look for the family history there. And then I think this is all just saying the same thing, watching for those red flags. This is the best way to kind of understand that cardiac sympathy is looking for those red flags. Some of my non-syncopal, they don't kind of fit into that category of 3. If someone has hyperventilation symptom, that might not be true syncope. Seizures may kind of present as this. I always have a lot of difficulty when I have soldiers with seizure disorder because no one wants to be in the military and have seizures. So they all said, oh, I fainted. And it's like, okay, but your friends said you were confused for 30 minutes afterwards. They may confabulate. They may make a lot of stories up. It may be kind of hard to tell. You may start on a syncope workup and then it happens a bunch of times and they may start having, my guy had a lot of bruising and cuts to his face. And I'm like, what's going on? He says, oh yeah, we have a barracks boxing league. And I'm like, I don't think that's happening at 3 in the morning, man. Like, you're actively bleeding. It turns out he was having seizures, but he was trying to say it was fainting episodes and was passing out and hitting random places at night. But make sure you keep seizures and presyncope, keep those workups together. Hypoglycemia can kind of present as this sometimes. Check the glucose early if I give you any kind of broad overarching diagnostic recommendations. Check hypoglycemia in a lot of these people. Acute hemorrhage, if we have a lot of blood loss, that can obviously cause us to pass out. What are some non-traumatic causes? Acute hemorrhage, yeah, he got shot. Of course he's passing out. What are some non-traumatic reasons why we might have blood loss? GI bleed is a good one if we have an occult bleed. Older alcoholics might have esophageal varices. That's a pretty big cause of issues. What about half of our population? Heavy menses. Can that cause issues in people? So check the CBC, especially if you're thinking these ones. And then psychological, these can present as fainting episodes. A good way to tell if someone's having true syncope versus psychological is watch what happens when they have an episode. If they take the time to get into a safe position, aka like lay down in a chair or like get down on the ground and then faint, chances are you're dealing with psychological. That can still happen in people that have like that prodrome and they know what's going to happen. But if someone's like always fainting in a very safe position, just pay attention to that. Are these people faking it, or are they genuinely having somatization? Somewhere between the two. Treat it like it's real always, because sometimes they don't have any control over that. It can be very frustrating where you're like, you're not actually fainting, and you're like, but I am, and they feel like it because their body's telling them because of psychological trauma to pass out. All right, I think this is just a quick comparison of that vagal-vasal versus the cardiovascular. Exercise-induced syncope should be cardiac until proven otherwise. We hit that pretty good. What is the position the patient is? Just for duplication's sake. Upright or sitting position, think orthostatic as they're standing up. If they're laying down, we're going to think cardiac because that's not orthostatic hypertension and that's not the vagal basal. And then these exercise-induced ones, think cardiovascular. Make sure we watch out for these ones of like where it's occurring. All right, some of the diagnostic tests. Does anyone know what this thing is? Does anyone have one done before? This is the new hotness, as in like it's been around for like 15 years. But this is a Zeo patch. It's not a lot nicer than who's ever had a Holter monitor done? Ton of spaghetti straps, it goes everywhere. You have to wear the little purse. They got this now. It's just like this little patch that you wear on your chest for a couple of days. Has a button you can push. You can put up to 14 days to monitor someone. When you're picking out how long you want to monitor someone, say, hey, how often are we having symptoms? Make sure it fits within that time frame. Don't put them for like 3 weeks every single time because they hate wearing it. But it's like, if it happens every day, hey, wear this for 3 days. If it's like once every 2 weeks, we're like, all right, wear it for 14 days. But they wear this, they push the button if they have symptoms. Doc gets alerted if there's like something super concerning, like if they're like in VFib. They call them. They don't really do that very often. But then all they have to do is mail that back in. They get results in a little bit. Fantastic. Always ask for the Zeo patch. It's great. Basic diagnostic tests, do your history, do your physical, take your orthostatic vitals, and then your EKG. And that should be enough to start. Do we want to get a brain CT or MRI on these guys every single time? No. It should be based upon, hey, I have other neurologic findings that make me want to get this. You don't have to rule out every single syncopal episode with a brain MRI. Same thing with EEG, the electroencephalogram. Unless I'm like really thinking, hey, I think this guy's like having post-ictal states. For my guy that was like waking up at 3 a.m. with the Barracks Boxing League, I was like, I think he's having seizures. EEG would have been a great decider for me. All right, EKG, do it at rest. EKG is great because I get a quick snapshot in clinic. I know he's not going to crump on me. But does that kind of give me an exact snapshot of what was happening when his episode happened? No, I got to capture it with that Zeo patch, that long-term monitoring. So I always kind of group those together. Autonomic testing is this tilt table testing. Has anyone ever had that performed on them before? Or sometimes we refer to orthostatic vitals as tilts. So what they're doing is they put you on this bed right here and they kind of shift you back over time, and they monitor your blood pressure. They may give you a couple of different things. People don't like doing this one. Typically it's not nice because you feel like you're going to pass out while they're doing it. You know, it seems pretty simple to be on a bed, but they just kind of gradually lower you back until you feel like you're going to pass out. I don't see this done a ton. It's a really good discriminator for like your high risk people, like your pilots or your people that like can't pass out and you have to like prove they're not going to do it again. The tilt table testing is a really good option for that. I have not done this a ton. It's not as common as you would think, but it's a really good if you like really want to rule out issues with people. And then exercise stress testing, GXTs. Love doing it for my active duty guys, especially if I'm like, hey, I'm concerned this guy's having like syncopal events related to exercise. I did my EKG, I know he's not going to die in office. I did my Zeo patch, I know he's not having episodes over a 14-day period. Let me actually put him on the stress test machine and see if nothing arises while they're doing that, because they actually watch the waveforms. It's not just, hey, here's how good you did. It's watching for development of arrhythmias while they're exercising. But those are my main ones I like to do. Making sure we're sticking to orthostatic vitals, EKG. Add these extra ones on depending upon what your clinical scenario says. Like, hey, I'm thinking more cardiac, go the cardiac workup. Hey, I'm thinking more neurologic, all right, go the neurology route. Sometimes, just in my own clinical practice, I try to send them to neurology and they say, we won't see them until they're cleared by neurology or by cardiology. And then I'll see the opposite go the other way where cardiology says, hey, we won't see them until neurology rules out. Usually the first one where you have to finish the cardiac workup before neurology sees them, that's okay, do the cardiac workup. Highlight this slide for you guys. It kind of is a quick summary of all the stuff that we talked about. I circled the boxes that I think are like really good differentiators between putting it into one of those three categories. When I deal with the reflex, think of like, hey, what are my triggers that are actually causing that to happen? And then common triggers with prodrome, pallor, sweating, nausea. Orthostatics, look for the polypharmacy, think of the additional deconditioning. Here are the kind of clinical scenarios that kind of tilt me towards an orthostatic. And it occurs while standing. That needs to be your trigger that I think orthostatic intolerance in these people. And lastly, cardiac, think of your red flag symptoms. And the prodrome may be absent in these people. It may just happen out of nowhere. But sudden without warning, often exertional or supine, that's going to be the level that we want to be able to differentiate these ones into. All right, we're through syncope. Let's move on to vertigo real quick. We're going to talk about the definition. We're going to discuss our clinical approach kind of in broad strokes. I highlighted these ones because we start to get into the more testable material and go like the different types of vertigo line by line. So just kind of pay attention to me on these two. Don't be like, oh, he's going to ask me a weird test question on this one. This is where I want to focus my test questions. All right. So vertigo is defined as a sense of rotational movement or a hallucination of movement. And it could be the patient feeling like he's moving, or it could be the room spinning around the patient. And it's associated with impulsion, which is this idea that I feel like things are moving even though everything looks normal. And then opsilia, so think ops as in vision, that's where like my actual vision starts turning and things are spinning. Nausea, vomiting are very common, gait ataxia. This can arise from a couple of different spots: the vestibular apparatus, the visual system, and the somatosensory. Those are our three things that tell us where we are in space. When we get disjointed information, either from left ear and right ear, that can cause a lot of issues, or if these are discordant with each other, it can cause a lot of issues that way. But the high yield thing, peripheral vestibular disorder versus centro-posterior circulation disorder. The big thing we have to determine is it peripheral vertigo or central vertigo? And we'll cover some of those different conditions. Just kind of a quick reminder from ENT. We got our semicircular canals, there's 3 of them. They got little hairs with fluid in there. As the fluid moves past it, that picks up as motion. We can get little stones that kind of get lodged in there and cause these abrupt movements of those hairs, benign positional vertigo. We have the otolith organ, that kind of senses more gravity. It doesn't cause as many issues with us. That's kind of more benign compared to everything else. But think of the semicircular canals as like a little gyroscope in your head. You know how your cell phone can change orientation as you move those gyroscopes? That's all that is inside your head. All right, so my general clinic approach, I like to get orthostatic vital signs on these guys just to make sure we're not dealing with like an orthostatic vagal-basal event, or excuse me, an orthostatic syncopal event. I look for nystagmus, and we'll go over a couple of signs of like slides of what nystagmus actually looks like. We listen for carotid bruits because we're thinking, hey, potentially basilar infarct is a potential issue with these guys for some of the central ones. So make sure you take your stethoscope out and actually listen to the carotid arteries on these people. And then we look for some of those cerebellar signs. Does everyone remember Romberg's at this point? I feel like we've beaten a dead horse with that one. We're looking for that wide base gait while they're walking, making sure things aren't wide and they're not ataxic in nature. And then intentional tremor can pop up in these guys sometimes. Then we like to do that finger to nose, heel to shin, rapidly alternating movements. Pull out those cerebellar signs when we're approaching someone with vertigo. And then lastly, hearing. I won't beat Weber's and Renee's into you guys. We're not testing crazy on it. But make sure we test for hearing, because when we affect those semicircular canals, we have a lot of conditions that can cause hearing loss as well. And that helps us differentiate a couple of those ones. But make sure we do the otoscope exam, do your rough finger testing. Don't be afraid to send someone to the hearing booth if you're trying to work them up, because it's very easy to get like definitive, hey, they have hearing loss or they don't, especially for your active duty folks. But I won't belabor the Weber's and Renee's test. I'm not going to test you on how to interpret that. All right, let me get rid of my laser pointer because this is a... So nystagmus, oh, come here. Nystagmus is this beating of the eyeballs. You can see it in this lady here. And it's kind of hard to tell at first because nystagmus has a direction to it. There's a fast movement and then a slow movement. And you can see her eyes kind of going to the right a little bit while you're watching the right of the screen. In reality, the nystagmus, that fast portion, is actually to the left. I'll play it one more time. See how the eyes kind of twitch left and then slowly come back right? Twitch left fast and then come back right? That tells you the direction of the nystagmus. What are some of the other forms of nystagmus we can have? Because that's horizontal, right? Vertical. Which one's scarier? Vertical. We'll spend a little more time because you guys got some of that during ENT. Think of the position, think of the amplitude, pay attention to the direction. The direction is very important for us. And then think that pendular nystagmus, think that jerk back. I was just trying to describe, hey, what's the fast component, what's the slow component? How do I describe which way the nystagmus is? And then saccades and pursuits. I think I referenced this earlier. I didn't really understand this when I left PA school, and then I got beat up by ophthalmology about it. So saccades is that fast eye movement. So if I have you stare at my finger over here, then over here, over here, over here, those are saccades. That's that movement. If I have a lot of issues where I'm like kind of having nystagmus come with saccades, or I'm overshooting rapidly, or I'm having difficulty moving between two different objects, hey, those saccades are broken down. And then pursuits are those slow eye movements. We check this without realizing it, but when we're doing that H pattern, watch just the quality of the, I'm like, okay, I'm watching for cranial nerve 6, but like, watch just the quality of eye movement. If it's really jerky, or they kind of like fixate, or they don't really hit it right, if those pursuits, those slow movements break down, say, hey, they have issues with pursuits. They're not specific findings to anything in particular, but they do help to kind of understand some of those eye movement issues. But here's just kind of a slide to show you what, we're looking for that quick jerk to the right. We're thinking right horizontal nystagmus. So a couple of different videos for you guys. So this one we're seeing, which way is it? Is it to the right or to the left? It's kind of hard to tell. I'll play it again. It's misleading because the eyes are off a little bit, but where's the fast component going? Correct. So usually peripheral nystagmus, meaning my safer origins of nystagmus and vertigo, are usually unidirectional, meaning it only goes one way. So as I move the eyes over and I see that nystagmus and it's always beating to the left, that's good. If it starts going the opposite direction once I cross midline, that's more concerning for central nystagmus. These are kind of the beginnings of how to do a really good nystagmus exam. One of the terms, I left it out because I feel like I'd lose you guys. It's way too far into the weeds. It's called a HINTS exam, H-I-N-T-S. And it's taking these findings and actually applying it to a rubric to say, hey, this is definitely peripheral or this is definitely central. I left it off because it's going to be way too much. As you move into clinical practice, like, oh, there's an actual exam that kind of puts this together and says, with greater specificity than an MRI, is this actually a stroke? And then I'm going to give you guys a view of what vertical nystagmus would look like. But here we see the eyes kind of twitching up. Where's the fast component? Is it up or down? Down. Good. It's kind of hard to tell at first because people will move their eyes. Just move the eyes around and check the whole thing. If I see nystagmus that goes either way or I see vertical, think, hey, this might be central. All right. Just some generalized things that kind of point you in the right direction. The nystagmus is a really good indicator. It's the first thing I look for when I'm saying, all right, is this peripheral? This is central. Peripheral tends to be short-lived, intense dizziness episodes. That benign positional vertigo, that covers a ton of territory for this one. This is typically affected by head position. Semicircular canals are involved, it's going to be affected when I change my head position. And the nystagmus must always be horizontal. It can't be pure vertical. We may have inner ear symptoms, we may have acoustic symptoms, we may have hearing loss. I think peripheral. Central is going to be associated with some of my more neuro reflexes. I may have motor sensory deficits. I may have hyperreflexia, which is an upper motor neuron sign. I may have more upper motor neuron signs. Ataxia, which is that posterior fossa localizer. I'm thinking, hey, cerebellar issues at this point. Or I may have dysarthria, as I'm having now. That's difficulty pronouncing things. And then central vertigo, just pay attention to these red flags. New focological neural deficit associated with it, severe gait or truncal ataxia, that direction changing nystagmus or that vertical nystagmus, those are more concerning. Headache or neck pain, that's more central vertigo in origin. And then vascular risk factors. Younger people, they're going to be more of the peripheral. Older people that are more prone to strokes, have a history of strokes, have a history of TIA, that should clue you into, hey, I need to pay attention to central for these people. And then inability to walk independently. Do you have a question?
Yeah, for the nystagmus and the peripheral vertigo,
Yeah.
Being in that fixed position, if they're in a position where they're not having the vertigo symptoms, will they also not have the nystagmus?
You can have vertigo without nystagmus. Usually if your eyes are kind of beating back and forth, you're going to have some degree. That's your semicircular canals, everything wired together, that your brain is wired to keep your eyes centered on a target and trace things. When those things are getting weird, abnormal symptoms, if you're having nystagmus, there's a pretty good chance you're having vertigo. Sometimes your body can suppress that over time. Does that help answer your question? Or is it...
I'll clarify on.
Thank you so much. I apologize if I was unclear. All right, peripheral, just kind of general descriptors. Again, make sure we don't have other neurologic things going on exam. All right, types of vertigo, we'll cover these ones real quick. Once we get to the end of this, we'll take a break. Some of these are very familiar from ENT, so it shouldn't be too nasty. I'll just clue you into my things that say, hey, clinically, I think this presents as this. Be able to recognize a patient, think about what's different. And I like this chart. This is what I used in clinic for a long time. I based it off of the duration of the episode, would kind of guide my recognition of these different ones. Benign positional vertigo typically lasts seconds to a minute. Vestibular neuritis, labyrinthitis, where I'm dealing with that inflammation of nerves, it's going to be typically on the order of days. Meniere's kind of close to that, maybe a little bit sooner. But now I'm thinking hearing symptoms being involved, labyrinthitis, Meniere's disease, both often involved. And then for that vestibular migraine, that perilimb fistula, where like fluid's connecting where I don't want it to be, I'm thinking barotrauma. Someone got hit in the ear by a slap fight, or maybe Carl Gustav. Those things can cause some issues where you have that leaking, where it's worse, especially with Valsalva, lends me into a perilimb fistula. But highlight this slide. It's really good to differentiate, especially like I used the time frame a lot to determine, hey, which one am I in? All right, vestibular neuritis, that's that paroxysmal vertigo, usually a single attack. It's pure vestibular neuritis. Auditory function is normal. So think vestibular neuritis, hearing's not going to be affected in these people. If hearing's affected, what does it turn into? Labyrinthitis. Etiology on this one, thought to be related to a viral illness. It's not like Guillain-Barré where I'm like guaranteed you're going to have an upper GI infection right before it happens, but sometimes it can be involved with that. But vestibular neuritis is going to be that acute sustained vertigo without hearing loss. That's going to be your clinical key to recognize this one. And if we have hearing loss, think labyrinth involved. Some of the ways we like to treat this one, glucocorticoids work great in the first couple of days. And then we can use benzos, work great to help in those first couple of days. Does anyone know the street name of meclizine? It's antivert. It's literally anti-vertigo. That's how I remember like giving people it. I was like, oh, he has vert, give him antivert. But meclizine can work really good in these people too. We don't like to keep these people on these medications long term because it actually affects your brain's ability to compensate for the signals it's getting. And it can prolong the episodes if you keep them suppressed for too long. But vestibular therapy, either through ENT or physical therapy, can kind of help if you have a lot of prolonged difficulties. It's very disabling when you actually have this happen to you. It's difficult to drive, you feel nauseous all the time, it's not a fun time. All right, labyrinthitis, very similar presentation, but now we're adding vertigo plus hearing loss. And treatments are going to be exactly the same. Labyrinthian concussion. Does anyone know what this is? Carl Gustav. It's a recoilless rifle. It causes a very large pressure differential around the ears. Think of this, guys, in your infantry people, your SF people that deal with a lot of explosives, because they end up dealing with a lot of overpressure around ears, especially in water with explosives. For some of my Navy guys, I've seen some SEALs with like pretty nasty like inner ear dysfunction secondary to like a blast wave. Water just transmits it a lot better. This one's nasty because the exhaust from the round is what manages the recoil, but as a result you end up with overpressure. I think training wise they're only allowed to fire it like 5 times in like a week or something like that without having to reset. But most common vertigo follows head concussion, can happen with this one. Secondary, it's kind of like secondary benign positional vertigo where we knock a couple of stones loose and that can cause a lot of issues. This is different than the, let me go back a slide. This is a little bit different than the perilimb fistula. Both of these can be caused by traumatic causes. This one gets a lot worse when we try to perform a Valsalva maneuver because it actually causes the fluid to leak out. Labyrinthian concussion does not get worse with Valsalva. It may a little bit. It's kind of hard to differentiate the two. Just be able to say, hey, there's no actual leaking of the fluid. It's going to be something that's going to be hard to differentiate clinically. All right, Meniere's disease, we got 4 more and then we'll go on break for a second. And then we're more than halfway through this lesson. All right, Meniere's disease, that's when we have too much fluid in that middle ear. Are you guys familiar with this from ENT? The way I like to think of this one, I got that tinnitus and that oral fullness, that feeling that my ear has a lot of fluid in it, but tinnitus is going to clue you into this one compared to other ones. Again, we don't know what causes it exactly, but look for that vertigo, look for that fluctuating low frequency sensorineural hearing loss. Not always going to find that, but tinnitus is going to be that thing that kind of points me towards a Meniere's disease diagnosis. This is going to be something that you're going to have a hard time diagnosing in clinic. Moreover, they're going to go to ENT and you're going to say, hey, I think they fit somewhere between this and considering Meniere's disease versus labyrinthitis. That's a perfectly acceptable way to send these people on. Has anyone ever gotten drunk and had issues with the room spinning? You have to put your foot down in order to make the room stop spinning while you're in bed. I equate that to Meniere's disease because what we're actually doing is we're causing that fluid to actually become way too fluid because we drink too much alcohol. It can actually get rid of some of the extra stuff that's in your perilimb fluid, causes it to be too fluid, it moves way too fast. So I always kind of equate Meniere's disease to getting the spins when you've had too many White Claws. First line treatments, salt restriction, diuretic therapy. We're trying to get some of that extra fluid back off to kind of help some of those symptoms. And vestibular suppressants, antivert is a good one to reach for. Meclizine, scopolamine. Has anyone ever done a scopolamine patch before? I like scopolamine. Don't give oral scopolamine, don't do the injection one. Do the patch behind the ear, you keep it on for 3 days. It works really good in these scenarios so they're not reliant on taking a pill, it just kind of gives them a constant level of suppression. But transdermal scope is a moneymaker. And then hearing aid and surgery potentially. This may end up fitting into a more chronic issue as compared to someone with like trauma where it kind of heals. All right, 3 more. Perilimb fistula. We kind of referenced this one before. Here we got a leaking of fluid from these ones, especially from those round and oval windows. Think of someone getting slapped in the ear pretty randomly. That can be kind of difficult to differentiate from the labyrinthian concussion. I think the one thing that may put one over the other for you would be like, hey, when these guys Valsalva, more fluid's leaking out because I'm putting pressure on that, so it can cause it to become worse. End of the day, differentiating between the two, I'm not going to give you a test question that says, hey, tell me labyrinthian versus perilimb. That's going to be a diagnosis made at the ENT level. That's not a PCM diagnosis to make the differentiation. All right, 2 more. Benign positional vertigo, posterior semicircular canal is the one that's most commonly affected. Brief positional vertigo, seconds to minutes, especially when we move our head around or we change levels. Think benign positional vertigo. It's the only one that's seconds and then it goes away randomly. Are you guys familiar with how to do Dix-Hallpike and Epperle's? It's kind of hit and miss sometimes. I won't belabor the point unless you guys want me to teach it on break real fast. Dix-Hallpike, I turn their head 45 degrees, I lay them back across the bed, and I kind of let the head lay down below the plane a little bit, and I just give them 2 minutes of uninterrupted eye contact. What I'm doing is looking for that nystagmus to develop. It may have a little bit of latency when that happens. It may take a second for it to pop, and then it pops up. And then they have feelings of vertigo. So have something for the patient to throw up in when you do that, or else you're going to be sitting there holding their head, they're throwing up, and you're staring into their eyes. It's like, I must see your nystagmus. Show it to me. Don't be weird. If we have that vertical nystagmus or neurologic deficits, don't fit it into a BPPV. I may give you a BPPV scenario and say, hey, is it BPPV? And they may have something weird neurologic going on in addition to, even though it's like slam dunk, don't fall for it. If they have other things going on, most of your people are going to fall on this relatively benign diagnosis. Don't fall for the trap if they got other things going on. And then Dix-Hallpike is great for diagnosing, yeah, that's Dix-Hallpike's. Move them back, see how things go. And then we can do the Eppley's repositioning. This one's always a little tricky because I like do it and then don't do it for a long time and then I try to do it again and I'm like, I don't know if I did that right. Again, similar to the other ones, we can cause symptoms when we do it. You're going to make someone become vertiginous when it happens. Have something for them to throw up in. Avoid pre-medicating them because then it's hard to kind of equate what's actually happening. But I start with the head. It almost looks exactly like the Dix-Hallpike. I then rotate over to the other side. I'll have them roll over in the bed a little bit and then I come back up. The best way I've seen it described is someone actually had like a clear semicircular canal that you like wear on the outside of your ear. And you could see what you were actually trying. There was like a little ball inside. And as you were positioning the patient through it, you could visualize the stones you were trying to move. It was one of the best ways I've ever seen it described. Best thing I can tell you, you'll get out of practice with it. Just look up a YouTube video of it real quick before you go see the patient. Don't watch the YouTube video with the patient while you're trying to do it. You lose style points for that. All right, last one, we'll go on break, guys. You guys are doing great. Vestibular migraine, this is a weird one. I've seen this actually pop up a bunch of times, and it can often like mimic a stroke. It pretends like it is, especially in younger people. It's going to be that vertigo episode in a patient with migraine history to begin with. It may occur with or without headache. Doesn't always happen. If you know someone has a history of migraines and they all of a sudden have like really bad vertigo that pops up out of nowhere, think that. But it may have some of those migraine type things of photophobia, phonophobia, visual aura, meaning we see something before it happens, and motion sensitivity. And this one can last for a little bit, days to weeks. Treat the migraines like normal migraines. I know we haven't covered headaches yet. Just reference it back to this later on, and we'll go over like, hey, here are really good ways to treat migraines. Just know you can treat the vestibular migraines in very similar ways. Dietary changes, avoiding triggers is a mainstay of avoiding migraines. Migraine prophylaxis and antiemetics can help. All right, let's take a 10-minute break. Might have grabbed the wrong mic.
No, they're going through the.
I have two mics. Two small ones. I don't know. Just wear them all. Can any sophomores hear me? Hey, I got a thumbs up. All right, good news is until seizures, there's like 11 slides left. It's not a ton of stuff. So we can get our feet wet into seizures if you guys don't want to waste some time of the block and stay ahead with what we got going on. Or are we kind of tapped out as far as neuro? Push. I can push. Can you pull? All right. You have no idea how I can push. All right, central disorders. Sounds threatening. God. All right, central disorders. So we got the peripheral ones. We're thinking that nystagmus that only beats to one side. It's only horizontal. I switch my gaze the other way, and it doesn't switch sides. That's pretty good. I don't have any additional focal neural deficits. There's nothing else scary. It's just simple benign positional vertigo. Or maybe I have an obvious history of getting slapped in the ear during slap fight in the barracks. Hey, that kind of adds up to more peripheral causes. Now we're going to talk about some of the more central scary ones. It's not just, all right, throw it all on central. Central vertigo may be sudden with stroke or hemorrhage, or maybe slow with tumor or degenerative disease. They're not always like, okay, everything that's fast onset is peripheral, everything that's slow onset is central. Can't cut it up that way. You got a little bit of overlap. All right, disequilibrium, cerebellum can be involved, basal ganglia, that bottom part of the brain can be involved. So we start thinking of that posterior circulation being involved with us sometimes. The whole brain can be involved, secondary to like central nervous system disorders such as like multiple sclerosis or systemic illness, focal generalized weakness. Basically, I'm trying to say, hey, a lot of different reasons can cause central disorders. Think of the cerebellum and basal ganglia being involved in these ones. Vascular infarct is a big one. Atriovenous malformation, meaning, hey, an artery and a vein are connecting where they don't want them to be, and that can cause that ballooning out to happen and cause issues. Tumors can cause some problems because, again, there's very little space here, so we start to see that uncal herniation. That can cause problems. And then chronic issues, people with MS, alcohol-induced can cause problems in people. Hypothyroidism can cause some issues in people, and congenital problems as well with the Chiari malformation. All right, I'm going to cover number 1, 2, and 4. These are our ones that we're kind of interested in. We'll pay attention to tumors later on in a different block. There's not a ton to brief here that's like specific or like, hey, it causes this very specific vertigo. Same thing with neurodegenerative conditions. These are the big ones that I want to pay attention to. So we're only going to cover these 3 just because we're going to cover those other ones in other spots. With the vertebrobasilar insufficiency or ischemia, I like this picture here because it shows me exactly what I'm talking about. I got these vertebral arteries. They're actually going up and through the different vertebral processes. So I think younger people with potential, it's my people that go to chiropractors and they get adjusted and it causes a ripping, tearing sensation, or potentially as I move my head back, that actually causes the issues to become worse. I think diplopia, dysarthria, dysphagia, limb ataxia, unilateral weakness, all these neuroscience, be concerned for these ones actually popping up. I guess your clue for this one would be some sort of manipulation or movement causing sudden vertigo in people. Drop attacks are a big one where it's like, I was fine a second ago, I moved it in the wrong way, and now I can't move. Visual disturbances, impaired balance. All right. The other one I think is TIA and stroke, and that's different than ischemia insufficiency. It seems like it's kind of like crowbar separation, but with a TIA and stroke, I'm actually dealing with something actually blocking the artery or vein from happening. When I think TIA or stroke, I'm thinking older people with vascular risk factors. New onset, difficulty walking, yes, this is all good. Drop attacks are very common in these ones. I think cerebellar stroke can mimic peripheral vertigo, but often causes severe truncal or gait ataxia. Again, if I'm thinking peripheral vertigo, but I have weird neurologic findings, go back to central ones. If it's an older folk, think TIA, think stroke. If it's a younger person with some kind of like movement of the neck, think of that insufficiency happening. Inability to sit, walk, or unaided is a major red flag. It can be difficult to tell in a vertiginous patient, like, hey, do you actually have neurologic deficits, or are you just like super dizzy, because they may fall over. If they're unable to sit or walk unaided, that's kind of a red flag that, hey, I need to move this more into the central causes. And then I think this talks about a couple of different treatments across. Sorry, don't pay too much attention to this. It's not really organized great for you guys. I apologize for this slide. For suspected posterior circulation, so that's my cerebellum, I think urgent neuroimaging and stroke evaluation are required. Early CT may miss posterior fossa ischemia, so don't be afraid to reach for MRI in some of these cases, just because those arteries and veins, once you start to get into the cerebellum, it's such a dense area, it can be hard to miss those things on CT. CT is great for catching hemispheres and everything else, but I think especially when I'm like, hey, this guy's vertiginous, I think the cerebellum's involved, I'm thinking posterior circulation, don't be afraid to reach for an MRI. I'm not gonna ask a crowbar, like, difficult question on that for the test, just for clinical practice's sake. And then MS. MS, about 10% of patients are going to present with vertigo. About a third of patients will experience during their course of having vertigo. And treatment is going to be based upon, all right, treat the underlying MS. As we kind of resolve some of those issues, we can treat symptomatically. We can also consider doing the vestibular rehab is a really good one for MS, but just be equating those two. All right. That does it for vertigo for us. We're going to move on to seizures here real quick, and we'll push until, I'm sorry, go ahead.
Sir, could you clarify what the phrase drop attack means?
So you asked me to clarify the phrase what a drop attack means. That would be someone that that was not a real one. We have one of our instructors, like, I think the kid stopped listening, and he just goes, oh, and just laid down dead. And we're like, do we do something? Or it was very strange, but now I did a drop attack as an instructor too. Life comes full circle. It's great. I don't think the sophomore saw me do that. There was no words. It was just action. All right. So seizures. Anyone can have a seizure. Has anyone actually had a seizure? You don't have to say yes. That's okay. But about 5 to 10% of the world's population will have it happen. We always think of like, oh, this person has a seizure disorder, they have epilepsy, they have recurrent seizures. There's such a thing as provoked seizures, meaning normal people can eventually be pushed, depending upon what's going on, to the point of having a seizure. When we cover pediatrics, we're going to pay attention to febrile seizure. Normal kids have a fever. Enough derangement can push you to the seizure point. But anyone can have a seizure, worrisome because they're so dramatic, and then conditions have a high likelihood of resulting in chronic seizures. Penetrating head wound blast, think of those ones, especially in your chronic TBI patients. I see a lot of comorbid new onset seizure disorder. So just some general definitions. A seizure is a symptom of an abnormal cortical activity. Electrically, the squiggles are mad today for the EEG. Epilepsy usually means recurrent or unprovoked seizures. So an unprovoked seizure means, hey, there was no external stimuli to cause me to have a seizure, it just arose of its own. Provoked seizures are different. Those are ones that are caused by something acute reversible insult, such as hypoglycemia, hyponatremia, intoxication, or withdrawal. So something is happening to have me have a seizure. Whenever you deal with a seizure patient, there's always going to be this rush to figure out, hey, was it provoked or unprovoked? Because that's going to change your management. And then aura is this idea of brief symptoms that may precede the onset of seizures. Those may be some really bizarre, like I almost think of like Spider-Man where he has his spider senses tingling. It could be you smell something, it could be you see something, it could be sudden onset nausea, it could be vertigo. A ton of different things can pop up. Just ask them, hey, did you know it was going to happen? And they say, yeah, I just have a feeling. Or they may be able to describe one of those for you. So etiology can be due to a primary central nervous system dysfunction. You just have straight epilepsy. It can be due to an underlying systemic disease or insult going on, or something drug-induced, something that we knew that caused issues. And we'll review this one later. It comes in a later slide. So seizures can happen to anyone. This comes up when I deal with flight medicine a lot. This is kind of like a next level as you become, right now you guys track disease states and you say, hey, this patient has weird symptoms, what's the disease? Eventually you'll realize that like normal people can have weird disease states to them. We can have normal physiology in abnormal environments. That's going to cause these things to happen. With seizures, they can happen to anybody. You put them in the wrong environment. I got hypoglycemia, hyponatremia, hyperosmolar states. I got hypocalcemia. Don't worry about the ups and downs. I like this slide, like this little portion right here that says the rapid shifts in glucose, sodium, calcium, renal function, osmolality. Anytime you have rapid back and forth, your body's trying to adjust to it, that's going to lower your seizure threshold. And we'll discuss the seizure threshold. It's a good thing to visualize and understand. Just know, hey, I can predispose normal people. I mess with their lights. I mess with a bunch of other things. I mess with their glucose too fast. That can cause seizures to arise. So what do I like to do with my people that have seizures? First off, was it a real seizure? I get a lot of people that come in and they say, oh, I had a fainting spell, and it ends up being seizures. Or I have people that come in saying they have seizures and it ends up being straight syncope. Try to differentiate those two and ask those appropriate questions. Think about clues that predispose that to us. Head trauma, stroke, AVM may cause issues in people if it's known. Precipitating factors, like what were you doing when it happened? Is sleep deprived? When we become more sleep deprived, that lowers our seizure threshold. Drugs or alcohol can predispose us to that too. Do your full neuro exam. Are we expecting abnormal findings on people? No. That should clue you into something a little more concerning than seizure, or seizure plus more. And then first-time seizure labs, I like glucose, get your lights in, get the pregnancy test if appropriate, because you're going to put them on medications that are going to potentially cause issues. Get the toxicology and alcohol, and get the neuroimaging, depending upon if it's relevant or not. A lot of times I'll end up getting the brain MRI, but do I want to get an urgent CT? Depends on my scenario. And I'll talk you through what that might look like. EEG. It's great if it's positive, because then I say, hey, guaranteed we're dealing with a seizure disorder. If it's negative, that doesn't necessarily rule everything out. It's just really good at like saying, hey, this guy definitely has epilepsy. Not only will they do kind of like the spot check one, but they'll also do a sleep deprivation one where they have you stay up for 48 hours and then check it and you have a seizure because you stayed up for too long. All right, with neuroimaging, I like MRI in these people, kind of like we were talking with that posterior circulation, kind of like we were talking about with the pituitary gland. For whatever reason, MRI is a lot better at visualizing soft tissue inside the brain. So that's going to show me a lot more of those fine little weird findings I'm looking for in seizure disorder. Non-contrast CT might be good in an emergency situation where I'm trying to say, hey, does this person have midline shift, or does this person have a mass, or does this person have an epidural brain bleed? Does this person have a brain bleed I'm looking for? That's good for this, but MRI is going to be kind of my long-term gold one I'm looking for. In the ER, non-contrast CT, perfectly acceptable, but know you're kind of going for MRI in the long term. And for my guys that have seizures and we know they have seizures and they're off their meds, do I need to get a brain MRI every single time? No, because I have a good baseline one and I'm moving on with my life. So I got two different generalized seizures that can happen, well, two different groups of seizures. I got these focal seizures that happen in one portion of my brain. They originate within the networks and are limited to that one spot. And these are called partial seizures. And then I can have generalized seizures. This is what you guys are probably familiar with from just kind of like lay terminology and social media. But this arises rapidly and engage both networks across the brain and results in loss of consciousness. So I put this up top here. It kind of shows you some of the different categorizations as we move through to kind of keep things straight. With focal seizures, I can either have awareness intact or in partial, and I can have nature of onset be either motor or non-motor. And we'll talk about what some of those different categories look like. I'm not going to ask you a very difficult question that's asked to apply the appropriate labels. I may describe some symptoms and say, hey, is this the most appropriate one? Don't worry about like, oh, it has to be this one or this one. It gets into the weeds a little bit with this one. I'll phrase it better when I'll do a practice question on this one so you kind of know the level and detail that we want to dig into this. So awareness meaning I'm aware that this is happening to me, or we can be impaired where we don't know what's happening. In motor onset, think of something motor happening versus non-motor tends to be a lot of weird findings that we'll go through. So intact awareness with motor. So I'm aware it's a motor onset. That could be tonic where my muscles are stiffening. That could be monoclonic where extremely brief 1 second muscle contraction, or that could be clonic where I kind of get this repeated muscle contractions. This is not a generalized seizure. I'm not seizing out at this point. It might just be one arm or one leg that's having seizure activity. I do have two named variants. These ones are great for the pants. They love asking questions about this. With Jacksonian March, think of like, hey, all of a sudden my finger starts tapping, and then my hand starts moving, then my whole arm starts moving, and I start going to the rave. It kind of works its way up into a central thing. It works its way up a limb as Jacksonian. Todd's paralysis is another good one. They're not, I have Jacksonian March, I'm going to get Todd's paralysis, just a separate strange finding. So I end up with a local focal onset of some type of seizure activity. Todd's paralysis, I won't be able to move that limb afterwards for minutes to hours afterwards. It can be a very strange finding. It may mimic a stroke because all of a sudden, hey, I have an arm droop or I have a facial droop after having a partial seizure. Just be able to recognize those names and say, like, they may describe a patient with one of those findings and say, oh, that's Todd's paralysis. Oh, that's Jacksonian March. It moved its way up. And then I can have these non-motor onsets, and we tend to be aware of these ones. Sensory might be tingling or numbness in a part of a body that, I'll make sure that's unhidden in the future. Hearing odd sounds, seeing flashes of light, visual hallucinations. You may get this weird cognitive shift, so all of a sudden you have this really intense feeling of deja vu, memory flashbacks, or trouble finding words out of nowhere. Autonomic, we may have a rising nauseous feeling in our stomach, flushed face, sweating, changes in the heart rate or blood pressure. And then emotionally, we can have sudden unprovoked surges of fear, anxiety, sadness, or joy. Sometimes that even happens to us while we're testing. If we have awareness of our motor symptoms and non-motor symptoms, we can have impaired awareness as well. These tends to be transient impairments, commonly arise in the temporal lobe, unable to respond appropriately. People may ask you questions and you just kind of look at them and try to respond and you think you're talking to them, but you're really not. They may have aura before this with the deja vu, some of those weird, some of those weird autonomic findings we can potentially see. The key to understanding that impaired awareness is they might not know that they're having deficits. They may talk to you and it sounds kind of like mush and you're like, are you okay right now? I don't think you're responding to me properly. And we may have some automatisms as well. Involuntary automatic behaviors that have a wide range of manifestations. That may be chewing, lip smacking, swallowing. They may display some weird behaviors while that's happening, but they're unaware that that's happening. That's the key to understanding impaired awareness. And then the last one down here is this focal to bilateral tonic-clonic. basically say, hey, this focal can start as focal and then work its way up to a generalized onset. And once we involve both hemispheres, that's going to affect our consciousness at that point. All right, generalized onset seizures. I got a couple of different categories. I got absent seizures. I got generalized tonic-clonic seizures, which you guys know in like common language as being a seizure. I have atonic seizures, which is kind of a weird variant of that. And then I got myoclonic ones, which is these are pretty easy to recognize. Just be able to recognize them clinically. So absent seizures, think of your young kids that start performing really poorly in school. It's almost as if you space out suddenly and you just kind of stare off into the horizon. That's a normal thing for most people to have happen, but these absent seizures, these guys are out completely. Even though they look perfectly normal, they may just kind of stare. It may happen up to 100 times per day. You're unaware that they're typically happening, so it's very difficult to say, oh, I'm having difficulty paying attention. It's like you're actually passing out and you don't fall over and suddenly have mild twitches either, so it's very hard to recognize it. But think of your kids that are having a lot of difficulty in school, and then you end up doing an EEG and it turns out they're actually having repeated absent seizures. They're absent from what's going on around them. And then ethosuximide tends to work really good. That's an anti-seizure medication, I believe. It's only for absent seizures. If I was going to ask a test question, this is the only one that uses that medication compared to other ones. That might be helpful to pay attention to. General tonic-clonic. Tonic meaning I'm locked out, or tonic meaning I'm not moving initially, and then clonic phase being that rapid movements back and forth. So that tonic phase where you drop down, you don't move for about 10 to 30 seconds, and then we'll see that clonic phase of those rapid movements. Respirations can be affected, tongue biting's common, sorry, it kind of describes these a little bit better. Extension of the body, but that clonic phase is where we see a lot of that, tonic phase second, this looks a little weird. Don't worry about the times. I think they mismatch between the slides a little bit, or am I back and forth? Okay, so that clonic phase where I'm having those rapidly alternating movements, I'm not expecting that to last more than a minute. Has anyone ever witnessed a seizure happen or taken care of a patient with it? It's always scary when it happens, right? And that whole minute, that lasts way longer than a minute. You see them seizing and you're like, all right, we're gonna wait for it to end up happening. A lot of that is just protecting the patient, make sure we're protecting the airway. Do I need to reach for and try to get IV access while the patient's actively seizing? Not in that first minute. We'll talk about when we make sure you track your time, because you see a patient seizing, it's gonna feel like forever. But protecting the patient and being ready for follow-on stabilization. And then we have this idea of post-ictal phase. That means after a seizure, I tend to be very out of it for 30 minutes, 45 minutes after. That could be complete unresponsiveness. That could be confusion about what's happened. This leads to a lot of difficulty in diagnosing people because they're unaware of what just happened to them, and they'll confabulate. They'll make up a lot of things and say, hey, 3 a.m. I was in the barracks boxing league. But EEG, sometimes you'll catch it, sometimes you won't. A person can have seizure disorder and have normal EEGs. It's very unlikely that you're going to catch an EEG of a patient actively seizing. So don't worry about rememorizing what these EEG findings look like. In general, I'm not going to test you guys on what an EEG finding looks like because I don't interpret those results independently. So don't worry about what the forms actually look like. That's for awareness. But some of my physical exam clues, especially when you get that guy that comes in, doesn't want to tell you he's having seizures or can't, look for that lateral tongue biting. Stick the tongue out and actually look for wounds on the side of the tongue. Urinary incontinence, we don't typically see that in vagovasal. When they pass out, they don't pee their pants usually. And then postictal confusion, support epileptic seizure over syncope. Look for the people that were around them when it happened and go ask them questions after because they'll say, yeah, he was confused for a good 45 minutes afterwards. He had no idea where he was. All right, atonic seizures last about 1 to 2 seconds. That's that sudden loss of postural tone. I think I demonstrated that a second ago. Consciousness briefly impaired. These guys pop right back up and they're fine, but think of your more drop attacks where it happens very suddenly. And then myoclonic jerks. This is where people suddenly, this person was just trying to brush their teeth. We have this happen to us normally physiologically. You ever be going to sleep and all of a sudden your leg kind of kicks out and you kick your cat off the bed? Don't ask me, that's very specific. So what's happening is normal physiologic. This may be kind of more, too much is actually happening in people where this is abnormal to the point where it starts affecting their lifestyle. Morning myoclonic jerks in adolescents, selective of juvenile monoclonal epilepsy. Don't worry about that too much. Just be able to identify if someone has a sudden jerk movement. Yeah, that can be a normal physiologic thing, but at some point it's bothersome and we may have epilepsy forms inside our EEGs. And this is what I was talking about with that seizure potential. You don't get a graph like this with a patient. We don't measure membrane potentials. But what we're doing is actually looking inside those nerves and saying, hey, here's how much we actually have to do before that depolarizes and causes issues. Normally, we have a threshold to where stimuli doesn't cause a ton of issues for us. And a person with epilepsy, or I give them medications that lower seizure thresholds, I'm moving this line down. So it's more likely that normal stimuli, like normal environments, will cause seizure activity to arise. Can I have a certain stimuli cause enough of a symptom in a normal person? Absolutely. But just pay attention. I kind of visualize it in my brain. Whenever I give someone like a medication I know lowers seizure threshold and I'm worried about it, I think I'm like, all right, I'm moving it down a little bit. Pay attention to that. All right, epilepsy. Can we drive while we're actively having seizures? Probably a bad idea. So this case actually happened to a friend of mine recently. He's a provider. He saw someone with epilepsy. Guy ran off and got into a car accident, and they ended up going back to the provider and saying, hey, you didn't counsel this guy that he wasn't allowed to drive, or you didn't do the state appropriate reporting to the Department of Transportation. And they're going after his license now because an accident happened as a result. Pay attention to this. You'll have a lot of difficulty for my active duty people. Your soldiers, your airmen, your sailors, they're not going to want to stop driving because then they're waking up mom and the kids to bring them into work. Rope the unit in, tell the first sergeant early and say, hey, this guy has seizures. He's not allowed to drive. He's not allowed to do airborne ops. Don't bring him to the range. Don't do this. No driving. Write the profile and follow up with those things. Talk to the first sergeant and engage like the leadership to actually start bringing them to work while the workup's happening. Eventually, and it depends state by state or even country by country when they're allowed to drive again, 3 months is the absolute shortest for like a provoked. A lot of that's going to be spent waiting. Don't worry about trying to clear people for driving again. That should be done with the neurologist as appropriate. But counsel them on it, write it in your note, write the profile, protect yourself from legal ramifications. I don't know why I always like my post-seizure guys, they drive around because they're like, oh, he can't listen to me. And I like see them like leave the clinic. I'm like, come on back, give me your keys, go get your first sergeant. Like be very hand-holding on these ones. Don't let them just go and say, oh, I don't know the law. You do have a responsibility. For people that are like in the civilian sector, pay attention to what your clinic says and say, hey, I actually have a reporting for my state, what I'm supposed to do for these. All right, seizure treatments, treat the underlying conditions and prevent reoccurrence and start them on anti-seizure medications. Metabolic causes, malignancy, medications, pay attention to things that lower the seizure threshold. Do a med-rec. Do you guys use UpToDate at all still? You can do a med-rec inside UpToDate and say, hey, look at these medications. Which one of these is most likely to lower seizure threshold? That can help you in those polypharmacy cases, or engage with clinical pharmacists early and say, hey, Grandpa here is on 19 different medications and now we have seizures. Can you help me kind of clean up his med list a little bit? That can be very helpful for you. We're avoiding precipitating factors. If we have some sort of identifiable trigger, avoiding that can be very helpful. Sleep deprivation, a lot of times when we write that seizure profile, it says avoid 24-hour duties. That's a really good idea. Don't put these kids on staff duties and predispose them to having more seizures. Alcohol intake should be avoided, especially in a lot of those anti-seizure medications. Just avoid that. I've seen a lot of cases of people with alcohol withdrawals be diagnosed as seizures because we feel like that is more likely to contribute to disability. It's less attributory. I'd much rather be diagnosed with a seizure disorder than I would alcohol withdrawal. I see people continuing to drink and having issues with continued withdrawal symptoms. Treat them simultaneously if you need to, but make sure we're counseling these guys, hey, we need to stop drinking. That's just lowering our seizure threshold even further. And then stress, avoiding stress. A lot of times you can stay in the military with a seizure disorder if you're seizure 3, but we're in a lot of situations where it's not a good idea, and we're in a lot of stressful situations where that can predispose things to worsen. All right, anti-epileptic medications. I think there's a bunch of slides at the back end that have dosages and types. I'm not going to go too far into the weeds as far as, hey, which anti-seizure medications, because I know you guys have gotten this informed completely. Eventually, we end up off these medications, and a lot of times we just have to be very careful about stopping anti-seizure medications because we can increase our seizure threshold by rapidly stopping. We want to titrate our way back off. The other thing I see with anti-seizure medications, just from a holistic perspective, compliance is very difficult with these people. And they'll continue to have seizures and say, oh, I'm taking it every day, and they don't want to. My one patient said his grandma was telling me the government was trying to control his body. And I'm going to say, yeah, we're trying to prevent you from having seizures. You can get lab values for most of your common anti-seizure medications as like a, hey, what's his Depakote level, or what's his Lamictal level? Go get those as like normal workup, just as force of habit every time you see these guys. Because then you can say, hey, this guy has not been taking his meds at all. He's still having seizures as a result, not a treatment failure or more underlying conditions. For whatever reason, people hate taking their anti-seizure meds. Big thing to watch out for most of them, checking our CBCs and LFTs, because they can be kind of hard. We watch out for agranular cytosis. We watch out for what our liver functions are doing. Check them at the 2, 1, 3, just kind of walk it out, so we're checking these more often. And then watch out for people on multiple drugs, making sure we're doing that drug, that med rec with either the clinical pharmacist or with UpToDate. They have a really good drug calculator in there to keep yourself straight. And then, do we know what Stevens-Johnson syndrome is yet? I got some nods because we had derm. I think the sophomores, can someone give me a thumbs up, thumbs down? They know Stevens-Johnson's? Cool. Don't worry about memorizing the different dosages here. There's a ton of different ones. I don't expect you to memorize them. I will kind of go through this kind of quick because we are at the end here and I enjoyed our time together. But I'm going to point out the ones that are typically, don't worry about like, oh, which one's first line for focal versus this. I'm going to give you my common ones that I see prescribed the most. Lamictal is really common. I see that one pop up. It's lamotrigine. They usually call it Lamictal. I see triliptal prescribed a lot, and that's oxcarbazepine. I see that one prescribed a lot. And then levetiracetam or Keppra. Who knows Keppra? I feel like some of us, does anyone do like TCCC type stuff yet? That's our favorite one. It doesn't have any drug-to-drug interactions, so I feel very safe given like, that's the one that I carry in my aid station with me. Kid bumps his head, I'm worried about him having seizure, so I want to load him up on Keppra. I can safely do that because I know there's nothing that's going to interact with Keppra. Dilantin, not really prescribing that anymore, causes that gingival hypoplasia. Tegral, don't see that really prescribed as much because of the side effects. The triliptal's just better. But Lamictal, triliptal, and Keppra are going to be like my 3 go-tos. Generalized tonic-clonic, nothing too crazy there, just very similar medications. I'm not going to give you a seizure type and say, hey, which one of these is the only one? That's way too much detail. It's pharmacy. I'm not doing that with you guys. All right. When do we like to discontinue? Usually like 1 to 5, 2 years is kind of the limit for that, for when they like to start taking people off. And you have to walk your way back off because you suddenly decrease it, it's going to increase your seizure threshold. You're going to have rebound seizures. And then lastly, status epilepticus. So what happens if I have a seizure? It should last about a minute. Goes past a minute, I go, all right, I'm a little more concerned. Once we hit that 5-minute mark, I'm thinking status epilepticus. The further we get away from that 1-minute mark, the less likely it's going to spontaneously discontinue on its own. So operationally, lasting more than 5 minutes, call it status epilepticus. Waiting longer, if you're like, I think it's going to go away. The longer you wait, the worse it's going to be. Start that stopwatch as soon as you can, because again, that minute feels like forever. So think seizure plus a little extra. Usually it's something like an anticonvulsant withdrawal that makes it really nasty. Metabolic disturbances is something like predisposed, but 2 on top of each other can cause these things to get worse and put you into that status epilepticus. CNS infection, CNS tumor, refractive epilepsy, head trauma, all those things. I think two things on top of each other can make it more likely to happen. And then what we like to do in these people, I think my benzos, be it the route, whatever you have available. If you have IV, that's great. Does IM work as well? No, it's going to take a lot longer for that to happen. We could still use it. Am I going to be able to get an IV line on a seizing patient? Probably not. Use what you have available and then follow it up with your anti-seizure medications so you prevent them from going back into it. Because even though you broke that seizure, they're still really close to that nasty, way past seizure threshold that put them in status epilepticus. And then don't memorize this, but there are some really good pathways that show you exactly what you want to do in a status epilepticus. Have some of these initial ones ready for like, all right, I know I'm doing use midazolam, IM, 10 milligram, cool. and then get my levetiracetam, get my Keppra on board, and then check for any immutable fixable problems. As long as you have this initial part memorized, you can go back and like, okay, I can find the rest of my chart later for what I'm supposed to do in this. Have this kind of ready for if you have a patient that's like actively seizing past the 5-minute mark, so you're not going, hang on, let me go back and check my slides for my PAP 3 years ago. That's a bad place to be. But no, hey, I want to get them on board with lorazepam if they start lasting past that 5-minute mark, and get some sort of anti-seizure medication on board so it stops happening, and then look for those reversible causes. Finger stick glucose, check your CMP real fast. And that is it. Thank you for tolerating me for 4 hours today. You guys are great.